Occupational English Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1.
Extract 1. You will hear a family doctor talking to John, a patient who has hay fever. For questions 1-12, complete the notes with the word or short phrase. You now have 30 seconds to look at the notes.
Well, good morning, John.
Morning.
How are you today?
Oh, I'm all right, I guess. I mean, I just think I've got some sort of hay fever or something like that.
Right. How long has this been going on for?
About, say, 2 weeks, maybe.
2 weeks?
Yeah.
Have you suffered from something like this before?
Yeah, I think I had a similar sort of thing last year. That's all, I mean, that's all I can remember. I mean, as far as, when I was a kid, I used to get a bit of asthma, apparently, but...
Right.
I mean...
But that's a little bit different to this.
Well, yeah.
And when you had this last year, do you remember what happened? How long did it last for, and what did you do about it?
Well, it certainly didn't last as long as this.
Right.
I mean, it was, I don't know, maybe a few days or something. I felt similar sort of symptoms.
Right.
But, this is, as I said, this has been going on for, I'd say, more than 2 weeks.
Right. Right.
And it doesn't seem to be letting up.
And you say your nose is blocked. Is it running?
Yeah, it runs a bit.
Yeah. What colour?
Sort of...
When you blow your nose, what colour?
Oh, it's sort of just, yellowy sort of.
Right.
Yeah.
And your eyes are watery?
Yeah.
Yeah, do they itch and scratch as well?
Yeah, they feel really red and itchy. And
when you wake up in the morning, are they stuck together?
Yeah, they feel... I really have to splash a lot of water in them in the morning to, just feel like I can get them right open.
Right. Well, is there a lot of sleep or gunk in your eyes?
Yeah, a lot of gunk.
Right, okay. And you've been sneezing a bit. Have you had any cough?
Yeah, I've been coughing up just a bit of stuff that, it seems to me like it's just sort of running down my throat,
Right. What colour are you coughing up?
Just the same sort of stuff as,
Right. And does that feel like it's coming from your chest, or it feels like it's coming from up in your head?
No, it's coming from my head.
Coming from up in your head?
Yeah.
Right, okay. And you tell me you had asthma when you were a child.
Yeah.
How severe was that?
Well, I guess it wasn't too bad. I mean, I had a spray.
Right, like Ventolin puffer or something like that.
Yeah. And just if I had a really, really active day or anything, I'd get a bit short of breath.
Right. And what age were you when you had the asthma?
That was like, sort of primary school, early secondary school, so around the age of 9. I guess it sort of started to phase out a bit by the time I was about 14.
Right, and since you're about 14, have you not had any asthma?
I don't feel like I've suffered any of those sort of symptoms. No.
Right. You haven't had to use Ventolin since that age?
No.
Were you ever, did you ever have an attack of asthma that was so bad that you had to be admitted to hospital?
No.
No. Okay,
No.
that's good. When you were a child, did you ever suffer from any skin problems like eczema?
No, not that.
Do you know what eczema is?
Yeah, like an itchy sort of thing.
That's right, an itchy skin rash.
No?
Okay.
No.
That's fine. Just tell me, does anyone in the family suffer from hay fever or asthma or eczema that you're aware of?
No, not that I'm aware of.
Okay. And how old are you now, John?
23.
Right. And you working?
Yeah.
Yeah, what do you do?
I'm a courier.
A courier.
Yeah.
What sort of things do you do?
I just deliver parcels, mostly around the sort of inner city area.
Right.
I just work for one of the firms.
Mm-hmm. And are you married?
No.
No, all right. And with your courier work, you're working full-time or part-time?
Full-time, yeah.
Full-time, right. And are you smoking?
No, I don't smoke.
You don't smoke?
No.
Does anyone at home with you smoke?
Sort of, yeah. I live with a guy, share a flat with a guy, and he
Right.
I mean, he's not a heavy smoker or something, he smokes a bit.
But he smokes in the house?
Yeah.
Right. And does that upset you? Does that make your nose run or make you sneeze or anything like that?
Well, I haven't it's certainly a bit uncomfortable now over the past couple of weeks,
Right.
but before then I haven't sort of noticed anything.
Right, okay. And do you drink any alcohol?
Oh, yeah, well, yeah.
What do you drink and how much? How often?
I guess you'd call me a social drinker, I suppose.
What do you mean by social drinker?
Well, I'll normally have a drink after work,
Mm-hmm.
maybe another one at home.
Right.
If I go out, like Friday or Saturday night, I'll have a few drinks.
Right. And what are you drinking?
Just beer.
Beer, right. And do you take any medications at all?
No.
Do you take any other drugs that you might get over the counter from the chemist?
Like Panadol, that sort of...
that sort of thing.
Yeah, I take those.
Mm-hmm. Have you tried anything that you get from the chemist for your hay fever?
No.
No. Mm-hmm. And are you allergic to anything that you're aware of? I mean, with regard to medications?
No. Not that I'm aware of, no.
Well, look, I mean, I think that you're right. I think the most likely diagnosis is hay fever.
Mm-hmm.
All right. The other name we use for hay fever is allergic rhinitis. Have you heard of that before?
No.
No. All right. Well, rhinitis basically means inflammation of the nose, which means that you get a runny, stuffed-up nose like you've got.
Right.
And allergic rhinitis is a runny, stuffed-up nose due to an allergy. And the sort of hay fever you've got is very common at this time of the year. It's springtime. There's a lot of pollen in the air. And you've got all the classic symptoms.
Yeah.
Now, we can do things about it, so you don't need to worry too much. To recommend to you is that we get you to take some tablets for your hay fever. All right?
Yeah.
And the tablets which I recommend to you are a tablet called Hismanol, and that's a tablet that you only have to take once a day.
All right.
And what you do is you take it once a day, and it lasts for 24 hours, and it should give you really good relief of these symptoms which you're having.
So how long will I need to take these tablets for then?
Well, what I suggest we do is I'll give you a prescription for about 10 of these tablets, and you take those each day for 10 days, and then you can come back and see me at the end of the 10 days, and we'll just see how you're going, see if they've actually made a big improvement to the symptoms, or see if there's something else maybe that we need to do at this stage. Now, there's a whole lot of different treatment options we can try. The tablets don't work, we can try nose sprays, we can try different sorts of tablets, a number of different things.
Are they expensive, these tablets?
Yeah, they are a bit expensive, but they cost about $1 a tablet.
Oh.
So it's going to cost you about $10 for 10 tablets. But it's worth it, right?
Oh,
And if it
okay.
takes the symptoms away, it's worth it.
Will this happen every year? Why hasn't it happened in the past?
Yeah, that's a really good question, and it's something which we don't really understand. For some reason, people do develop allergies as they get older. And, for example, with your asthma, you didn't develop asthma until you were 9, so you had 9 years without it. And it's the same with the hay fever. You haven't had any really symptoms like this before. Now, it may be that this year there's something in the air which you're particularly sensitive to, and there's a lot of it.
Right.
And it may be that that's been due to a lot of rain or the recent spurt of hot weather or whatever. I mean, who knows?
Yeah.
So we've just got to take this year by year. And I think you'll find that the symptoms you have got should resolve over the next couple of weeks, and certainly the tablets will help to keep them under control.
Extract 2. You will hear a general practitioner talking to Phoebe, a woman with the problem. For questions 13 to 24, complete the notes with the word or short phrase. You now have 30 seconds to look at the notes.
How are you today?
I'm okay, thank you.
Phoebe Johnson is the unusual name Phoebe. We don't see many Phoebes coming through.
Was a name my mother loved, which I've come to live with.
And you've not been here before?
No, I haven't. I've come for a second opinion, actually,
okay.
if that's all right.
Oh, look, that's what I'm here for, I guess. So, who's your normal doctor? How is it? Local?
Well, I don't really have a normal doctor. I used to go to the university doctor in my previous job.
Uh-huh.
And this complaint dates back to then, but I've done nothing about it for months and months, and I just thought I'd better come and check in.
So what problem was that?
Well, it's kind of a complicated story. I went to the doctor it was probably over a year ago now when I think about it. I was having pains tingling feelings in my arms and stuff, and I was at night, and I was worried about it. And in the process of trying to work out what that was, the doctor actually discovered I had a lump on my thyroid. He noticed a sort of swelling in my neck.
Well, is the thyroid lump still there?
I think so, but it's never
looks like it's all. Well, I'll examine it shortly.
And he sent me off to have tests, and I had a series of tests which I can try and tell you about.
You would have had blood tests done, scans, nuclear scans done?
I'll try and remember the order. I think I had a, ultrasound. And that revealed I had a lump in an unusually large lump in my right thyroid and some other lumps in the left-hand side. And the doctor then sent me to an endocrinologist whose name escapes me at the moment, but it will come to me. And he looked at the ultrasound results and suggested I have a sort of a biopsy or something like that, and various blood tests.
And that's been done?
That was done ages and ages ago.
What did that show? Do you remember?
Well, yeah, I do remember quite well. It showed nothing sinister.
Good.
And what the doctor said at the time, the specialist said that although it showed nothing sinister, because this lump was larger than a certain number of centimetres or something, that he would recommend having it taken out and looked at, because often abnormalities don't show up in these biopsies.
Did he refer you to a surgeon, the endocrinologist, or you just decided not to pursue that?
No, it got to the point where he actually booked me, or maybe he was a surgeon himself, but he booked me into a hospital to go and have an operation on my thyroid, which I never did. So, and at the time, I'd just come back from overseas, and I wasn't on private health cover, so he booked me into a public hospital.
Yes.
And I was pretty nervous about someone cutting my throat that I didn't know, basically.
Oh, well, look, I'm sure he'd be a competent sort of surgeon.
But it wasn't clear that he would be doing the operation.
No, well, look, I think public hospitals are very good. I think I deal a lot with the public system, and I'd have confidence in any surgeon cutting my neck open in a public hospital, especially if there was a need to have it done. So that shouldn't be an issue from your point of view. I think, do you have private insurance now? Private medical insurance?
I do now.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
Hello, Miss Pendeline. I'm getting ready to go home. This is going to be your night nurse, and she's going to take really good care of you tonight. Okay.
Hi, good evening, Miss Pendeline. My name is Beverly. I'm going to be your nurse tonight till 7 in the morning. Can I check your armband? Can you state your name and your birthday?
Nadia Pendeline, 726-75.
Do you have any allergies?
No.
All right. I'm just going to get a report from Melissa.
Okay, so Miss Nadia came to us from the ER. She's a 40-year-old female who was admitted for chest pain. She's had 2 negative troponins so far. Miss Nadia, that means the labs they drew downstairs to check your heart muscles for injury have come back negative so far. So she has a cardiac diet, so you can go ahead and eat your dinner tonight, and then NPO after midnight, so nothing by mouth after midnight until tomorrow morning for her stress test. She has a right forearm 20 gauge with normal saline at 75.
I'm going to check your IV.
Miss Nadia is alert and oriented. She can ambulate with assistance. She did report some dizziness in the ER, so we have a fall wristband on her as well as the yellow socks.
Question 26. Now read the question.
I have 2 patients on the geriatric service. The first one is in room 4242, Mr. Appleton, patient of Dr. Abel and Dr. Coder.
So he's had 2 strokes in the past and has some cognitive impairment.
On the other hand, the care partner said he was saying this morning, I want to die, I want to die. He did not say this to me, but he definitely has signs of depression.
Yeah, apparently his wife is in another SNF, and she stopped visiting him, so he's convinced that she's dead. So Dr. Mitchell called me this morning and gave me the information where the wife is, so we need to figure out how to get them together.
In the same SNF?
In the same place.
Okay. Where is his wife?
West Harbor Convalescent Center.
Oh, that's far.
Yeah, and the phone number I got from Dr. Mitchell is 310-555-1112.
555-1112.
Yeah.
Question 27. Now read the question.
All right, I have 5216, Mr. James. He's a 72-year-old male patient of Dr. Carter.
So he went yesterday over to the University Hospital for a stent for his new diagnosis of gastric carcinoma. He apparently doesn't know. He's not aware of the diagnosis, of which I wasn't informed of initially. So I guess his family was waiting for another son to arrive before they told him today.
And who's going to be there with them for this conversation?
We will, and...
Yeah, I'll be there.
So he tolerated the procedure fine. He was going to get transfused 2 units last night for his low hemoglobin. But after the first unit, his temp spiked to 1016. It's not clear if this could have been a transfusion reaction. He's also very tacky. He seemed tacky today. You know, he's going to have to be here another couple of days until we figure out the source of the fever. We have cultures pending. We can get the RUA and the urine culture, and the chest x-ray so far looks okay.
Question 28. Now read the question.
How are you? Dr. Russ, Dr. Welke, how are you?
So nice to meet you.
Well, I'm the neurologist, so they asked to come and see your daughter. The problem is that, fortunately, she doesn't have a brain tumor, but these spells we have to treat, And the medication she's on is not as good as the one I want to put her on. So I'm switching her to something called Keppra. And frankly, I don't know how to put it into the computer system, so I've asked our resident to come here and help me do that.
This is where we put the order really quick. Okay, but we're going to start that med today?
We're starting that med today, but the problem is, because we're starting a brand new medication, we have to keep her in the hospital for at least 2 more days just to watch for potential side effects and allergies. As a rule, they don't occur, but it's better to be safe than sorry.
Okay, sweetie, we can't go home. I'm sorry.
Is it okay, Kara? You're going to have to stay, okay?
We'll watch some movies.
Okay.
Okay. They're not going home today?
No, they're not going home today.
Okay.
Question 29. Now read the question.
You fainted in the past, over the last couple of years? Do you faint?
Oh, yeah. Well, I just fall down without any warning. I'd be walking in the street merrily along the way, and then I'm on the floor. Okay.
How many times has that happened?
Must have happened 6 times or so.
Did you know you were going down, or you had no warning?
No warning.
So this is really true syncope. Well, look, we're going to look at your heart and see what vessels are blocked, if any. We don't know yet. And then we're going to have to take care of your fainting. So you're going to take care of the diabetes, and we'll take care of your fainting. How's that?
Well, that's the deal.
Is that a deal?
Good deal.
When did you begin to feel that something was wrong?
Well, 4 years ago, I began to feel that something was wrong, but that I was having difficulty walking and that I was collapsing in various ways. And then on Saturday, I could no longer even get a piece of bread out of it.
Really? Did you have chest pain?
No pain.
Nothing?
Just that I was just absolutely wiped out.
Question 30. Now read the question.
Safety and quality of patient care is the top priority of the Trust, and this short video will describe an important safety improvement programme which has been called Sign Up to Safety. Last year, the Secretary of State for Health set out the ambition of halving avoidable harm in the NHS over the next 3 years and saving 6,000 lives as a result. Sign Up to Safety is the national campaign that aims to support this by listening to patients, carers and staff, and learning from what they say when things go wrong. Taking action to improve patient safety, ensuring wherever possible patients receive harm-free care every time, everywhere. Sign Up to Safety aims to strengthen patient safety in the NHS and make it the safest healthcare system in the world.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
Good morning. This is Dr. Marvin. You're listening to Let's Talk Dentistry. Thank you for joining us. Today's show is going to be about cavitations. Now, our dentistry is totally different from other dental offices. We take a whole body approach. Now, what is a whole body approach? Well, we mean that we look at you as a person, not you as a bunch of parts and you have teeth and gums and we just wait for the teeth and gums to break before we fix something. No, we look at the whole body approach. We feel that your health, your long-term health, is a function of what's going on inside your body. And if you're feeding your body the good building blocks it needs to heal itself, then you're going to live a long, healthy, prosperous life. However, if you have problems in your life, in your health, then it's probably because there's a process breaking down inside your body and you need to find the right person to fix it. So we're health-oriented, not tooth-oriented, and that's the big difference between us and other practices. One of the other things that we like to do is we like to determine the cause. If you have a problem and you have some symptoms, you need to determine what was the cause of those symptoms, not just try to cover it up. It's too easy to take a medication to cover it up, or easy to take a supplement to cover it up. But if you're not figuring out the cause, then you're not really figuring out the problem. So what we do is we try to figure out the cause of the problem so that we can make recommendations on how to treat the cause so that we can prevent future problems later on. The other aspect of our dentistry is that we use certain technology, certain skills that we aren't taught in dental school. And since we aren't taught in dental school, we have to go out and search it ourselves. So we have advanced techniques, advanced technologies that we've invested in a lot of hours, a lot of times, and you just can't say that all dentists are the same, because we're not. We all have different experiences. We all practice differently. They are called to practice. There's no exactness to this. And if you think that all dentists do everything the same, then you must be from a different planet, because all dentists, just like all other technicians, are different. Not all mechanics are the same. Not all doctors are the same. Not all veterinarians the same. Not all plumbers, electricians, builders. They're not all the same. So stop thinking about dentists being the same and stop thinking that what they do is the same. It's absolutely not true. A couple of stories that I want to get to this week. Someone came to see me about a tooth that had been bothering her for months. It was actually on the lower left side. It's been bothering her for months. She has a hole in the tooth. She has a big cavity, so she went to her dentist, and her dentist sent her to an endodontist. An endodontist is a specialist in root canal therapy. What they do is they do root canals almost all day, every day. Well, the experience that she had when she went to the endodontist was, in her own words, a nightmare. Yes, she had a total of 9 shots given to her, and she still couldn't get numb. I don't know how long it took, but they kept on giving her more and more shots. Well, in the end, what we figured out was that most dentists use the same types of local anesthetic. And in our office, when she came in, I tested her with the anesthetic that most dentists used. And she was highly, highly allergic to it. So that's why she did not get numb, is because that's the wrong anesthetic. So she is an individual. She is very unique, just like all of us. And dentists are not trained to determine which anesthetic is best to use. This is something routinely that we do at our office, and we don't charge an additional fee for this. So needless to say, it was a good idea that she didn't get numb. Powers stepped in, and she did not have the root canal done. So she came to see me, and it was determined that we are going to actually save the tooth without doing a root canal. And we're not going to extract the tooth right away. We're going to try and save the tooth. We're going to use... The reason why we're going to save the tooth is because there was no infection at the root or around the apex of the tooth. That's very important. So if there's no infection at the apex of the tooth and the tooth is still alive, we're going to try and give this tooth a fighting chance. We're going to try and revive the tooth. And that involves removing the cavity, being very gentle with our technique, not to disturb the nerve, and we're going to use ozone, and we're going to revive the tooth. It's like CPR for the tooth. It's pretty amazing that we can do this, but it requires a lot of skill, know-how, and technology.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Our guest this week is Dr. Jonathan Friedel, a good friend of mine and also a transplant surgeon here at Indiana University School of Medicine. So I'm going to let him introduce himself first, and then I'm going to ask him lots of questions.
Hi, this is Jonathan Friedel. I'm Chief of Transplant at Indiana University. I mainly specialize in pancreas transplants, but I'm kind of a jack of all trades. I do livers and bowels, and used to do kidneys. I'm originally from Montreal, and I've been in Indiana now since 2002.
So how do you get to be a transplant surgeon? So clearly you went to college first and then medical school. Where'd you go to medical school?
I went to medical school in Montreal.
And then what did you do after that?
So the training in Montreal is a little bit different because they have a different schooling system. So instead of going to grade 12 and 13, high school actually goes to grade 11, then we do 2 years of college. After that, I went to an early acceptance program at McGill for medical school. Following medical school, it's a 5-year general surgery training for residency. There was an opportunity to spend extra time in the lab, and I took advantage of that. I did 2 years. And then following that, it's a 2-year fellowship in transplantation. And after that, you go look for work.
So to become a pancreas transplant surgeon, is there any extra training to specialize there, or is that just part of the general transplant fellowship?
So in order to become a pancreas transplant surgeon specifically, most people go through training for multiple organs, and the program you train at has to have a certain number of pancreas transplants that they perform a year so that their fellows get enough experience they can start.
How do you know you want to be a pancreas transplant surgeon?
I didn't originally want to be a pancreas transplant surgeon. I think originally I wanted to do livers and intestines, and I really was interested in pediatric livers. And what ended up happening is when I came to Indiana, I noticed that, like many other programs, they would only do pancreas transplants when there was an ideal offer with an ideal recipient. And I sort of felt like there was a lot of organs here that were going to waste or were being sent out to other programs. And I originally became interested as an attending because I wanted to not waste those organs.
All right, so let's back up for a second. Can you explain what a pancreas does?
Sure. Pancreas is an organ in the upper abdomen. It lives in the back of the belly. It's an organ that participates in digestion, and it also participates in the endocrine system. And the part we're interested for pancreas transplantation is the endocrine part. Pancreas makes insulin and glucagon and somatostatin and a bunch of other hormones. Particularly of interest is diabetes happens when you don't make enough insulin. So we transplant a pancreas so that we make people who don't make insulin.
So a pancreas transplant effectively would cure type 1 diabetes?
It's sort of like an ideal treatment for it.
Why don't we do it for everyone then?
That's a great question. Actually, the most common consults we get are patients that are well-controlled diabetics, and they're sort of looking down the line and they're worried they're going to lose their vision or they could develop neuropathy or kidney problems, and they want to just get a pancreas. But the balancing act is you take a person who's taking lifelong medications and at risk for chronic diseases, you do a big operation, first of all, and second of all, you put them on immunosuppression medications for the rest of their life. So instead of being a diabetic patient, they become a transplant patient, and it's not really worth that risk unless there's something else that tilts the balance. By far the most common reason to do a pancreas transplant is that they're already going to get a kidney transplant for diabetes-related kidney disease. So you might as well also put in a pancreas so they won't be diabetic. And basically you've taken all the risk of the immunosuppression off the table because they've already committed to lifelong immunosuppression for the kidney transplant.
So it's like a +1 operation. Like, as long as you're getting another kind of transplant, we might as well fix this at the same time.
Well, first of all, the patient survival is better if you get both organs. And the survival on the waiting list for patients who are diabetic and have kidney failure is amongst the highest. So this is a really at-risk patient population with a huge benefit. So it's not decorative, but there are also patients that have life-threatening complications from their diabetes. In fact, in patients like that, we would do a pancreas without a kidney. The most common of those is hypoglycemia unawareness. Those would be patients that have low sugars. They don't get any warning signs. So they first find out that their sugar's low when they wake up on the floor. Somebody has to revive them. Somebody has to give them something sweet. Frequently emergency room visits, EMT calls, and hospital admissions for this.
So I'm sort of fascinated. How do they fix the timing? I imagine if we're going to do it with a kidney transplant, then we have to either have some kind of aligning of the stars that a kidney is available at the same moment a pancreas is available, or is it something that if they've already had a previous kidney transplant and they're therefore on immunosuppression, later we can do a pancreas transplant?
So that's a complicated question because we could do either of those. Frankly, when I see a patient who needs a kidney and a pancreas, like all regular kidney patients, I ask them if they have a living donor. And it is possible to get a kidney first and then follow that with a pancreas at a later date. Much more common is to perform both organs from the same organ donor. Pancreas graft survival is slightly better, but the waiting time is longer, and there's all kinds of pluses and minuses for that. But the way the allocation works in the country, if you are listed for a kidney pancreas and your pancreas number comes up, then the kidney travels with it.
Okay.
That is the end of Part C. You now have 2 minutes to check your answers.